Dear Pure Urology Facebook viewers, good evening one and all. After a gap of 4-5 days, we are coming back today with a totally interesting new different topic apart from our surgical techniques. But for all the urologists, especially general urologists who deal with stones, you all know that in the present era, prevention of the stone disease is a very big topic. Naturally, every patient after getting stone treatment, whether medical or surgical, says that can I prevent this stone forming again? So in this process, I got since time a good speaker who has lot of experience in this. Ultimately, I found Dr. Sanjeev Mehta sir, who is the director of the Urolab from India, Ahmedabad, and he consented to give the talk. So Dr. Sanjeev Mehta is uropathologist. I will share his screen before the talk is handed over to him. So today talk session is stone analysis and metabolic workup for stone prevention by Dr. Sanjeev Mehta. So Dr. Sanjeev Mehta is uropathologist. He is director and promoter of India's only of its kind specialty lab, pathology lab on kidney stones named Urolab. Most of the urologists know this. He has received training in Sloan Kettering Cancer Center, New York for cancer diagnosis in pathology at Armed Forces Institute of Pathology, Washington DC, USA. He has so far completed more than 60,000 stone disease patient sample. Dr. Mehta is honorable biocrystallographer at Louis Heng Laboratory, Orlando, Florida, USA, where he worked and trained for stone analysis. Dr. Sanjeev Mehta is also instrumental in bringing overseas patients to India for medical treatment. He has helped and contributed in many studies, research projects related to stone disease of leading institutions of India and abroad. He has publications in national and international journals also. He was invited as international faculty in China and UAE also. He is active in many social activities also. He was president of Ahmedabad, Gujarat biggest Rotary Club Ahmedabad Metro, and involved in many community service projects. With this introduction, I hand over the program to Dr. Sanjeev sir. Sir, good evening. Thank you once again for accepting the invitation. And you have chosen a good topic after our initial discussion. You only have properly guided me the topic so that it will be interesting. Lot of response has come from the audience that we wanted to listen this topic. Let's hope this will be useful for all the youngsters who are doing stonework. Thank you, sir. Over to you, sir.
Yeah, good evening. And thanks, Dr. Chandramohan, for giving me this opportunity. I think this is a wonderful initiative you have taken, and everybody, many people are being benefited for this. So now let us start.
Yes, sir.
And should I share my screen?
Yes, sir.
Yes.
Yes, sir. Visible.
Is the seen?
Yes, sir.
All right. So as you said, this is the today's topic is somewhat beyond surgery, and obviously this is very interesting. And I have noticed that the interest in this field is gradually increasing more and more. So in next about an hour, we are going to talk about that. Right. So we know we have mainly it has issues like it has a high incidence, especially in India. Like we have many stone beds. For example, our Gujarat itself is a big stone bed adjoining Rajasthan, Punjab, the North India itself. But the worrisome is that this disease is having tremendous chances of recurrence. So recurrence is main headache because it comes back again and again. Patients gets troubled, and even they ask urologist also why this stone is coming back again. And that is how we need to focus mainly on the preventive aspect of disease. So I'm just going to focus on that. And many times what happens, there are underlying abnormalities also up to the patient who suffers from the stone disease. The objective of management of any disease, but particularly for stone, has to be one is to make the patient free of disease, and secondly, we should take all the steps to stop the recurrence of the same disease. Now, a right approach or right treatment can be possible once we know the exact cause of the stone formation. Prevention, especially this is not a myth, but it is attainable objective. We need to take the stone specific treatments. And while doing that, supersaturation of the urine is the key factor. I'm going to discuss same thing in further details. Ultimately, the prevention is the long-term goal. It's not a short-term or within a week's goal. One has to follow it for a very long period, which involves in the changes of the diet of that patient, its lifestyle, and obviously, if required, the medications also. So while managing the patient of stone disease, we must look for the possible preventive cause, if any. Lab reports, now it can explain whether patient's treatment is achievable or it has been achieved as per goal or the design of the treatment. Laboratories plays a key role in this field. What lab cannot tell you, you will not know by your perceptions. What labs tells you in error, you will not correct by your instinct itself. So a very accurate, we diagnostic field people are having a major role to, we cannot afford the errors actually. And while making error, there is, you know it, there is no expense is as unreasonable as a misdirected treatment for that particular patient. The management, if we see a patient, if we take general measures by treating a patient, the 60% of the patient comes back with 3 years period. And this has been studied also. But if we investigate properly, if we take specific measure based on the evaluation of the patient, that rate goes down to 50 to 15 to 20%. So this shows remarkable improvement in the recurrence. Just it's a basic thing. Like we have two types of component when stone is being formed within our body. One are the stone promoters and one is the stone inhibitors. Wherever there is imbalance and wherever the promoters dominate, like calcium, sodium, oxalate, uric acid, or inhibitors are deficient. For example, inorganic magnesium, phosphorus, citrate, there is production, the supersaturation of the urine. If I explain you in simple terms, the supersaturation, I just got an example. Like if we dissolve some salt in water, it gets dissolved. But when keep on going, adding it, at one stage they will stop dissolving. There we say it's a basic chemistry that this solution is saturated. But once we heat it, again that salt start dissolving. At one stage, that also stops. That solution is called as supersaturation. So similar things, these salts, they with our within our body, and the urine becomes supersaturation because of all these factors combined: calcium, sodium, oxalate. It doesn't mean that if calcium is high, then stool will definitely form. It's a combined effect, and that ultimately supersaturation of the urine, which is causing the stone formation. So with this concept, we'll move forward further. While evaluating a patient in laboratory, there are three main things to be done. One is the blood and urinary test as a part of routine. We evaluate the patient. We just prescribe some routine test based on patient history and the clinical status. Another thing is which is very important is the stone analysis and the 24 hours urine metabolic profile. This has to be done along with the supersaturation. It's a supersaturation is a calculation which is based on the all those factors which I have mentioned. Now, the new advances has come, like in every field. We can find out with this blood and urinary test, the most of the time the cause of stone formation. And once we know, we can take very specific prophylactic measures also. Going to the blood, these are the routine tests: electrolyte, calcium, potassium, phosphorus, and so on. And urine, especially specific gravity, pH. This indicates lots of things, nitrates, then other things. The sediments of the urine are very important. No pathologist should ignore the sediments also, and they have specific, they tells this real story also. As and when required, a patient we suspect some pus cells or there is infection in the urine, one can ask for the urine culture also. Based on this test, these are certain conclusions we can draw. Like if a patient is having low potassium and bicarbonate, one should suspect renal tubular acidosis. High uric acid, we know that is uric acid diathesis causing the uric stone formation. Persistently high calcium, one should suspect a primary hyperparathyroidism. Whenever there is low phosphorus, think of the renal phosphate leak. Similarly, parathyroid estimation should be asked as and when required. In urine, the pH, if it is very alkaline, more than 7.5, one should think of the infection lithiasis. And if it is very acidic, then one should thought of the uric acid lithiasis. These are just basic fundamental things. Sediments should be seen for crystalluria. Then comes the urine culture. Cystine is a very important thing. But this should be done qualitative also, because if we go for qualitative test, it's a very, very economical test. Quantitation is in cystine in this country is not done, and if at all it has to be sent abroad, this costs a lot. It's in many thousands. And one should screen following things for the primary causes. If we can find out these causes, which are generally, means many times they are very easily missed, because one should focus initially on these things whenever patient comes. So here is the list, so we can understand the parathyroid hormones, vitamin D excess. Even one should think of distal renal tubular acidosis. Sometimes, many times, the calcium supplements patient keeps on taking, that can also cause of. Many times primary hyperoxaluria also, whenever diagnosed, then it's already very late. So all these things, if we want to prevent the stone, this diseases should be kept in mind, because this diseases, they give immediate solution of the issue. Coming to the stone analysis, I will just talk briefly about the technique. This is a very important thing, and it should be done with every stone. It's a very, very cheap test, and there is no need to throw the stone. You just go and get its analysis done, because it can give this entire story also. Stone is not just 2-3 types. This is just a list of, there are about 65 different types of the chemical compounds which are found in the stone analysis. One side is the list of those stones which are frequently found, and these are the rare stones. These are, for example, 2,8-dihydroxynine. These things, because we are getting samples from all over all around, we are getting a good number of these types of the rare stones also. So stone analysis is a specialist investigation. It should be performed in a places where it is done exactly, because 90%, either more than labs are unable to analyze. These are Western figures. A stone which is less than 10 milligram of stones. And this leads to inappropriate therapy and misdiagnosis also. And then this causes the wasteful further investigations. So one should be expert in analyzing the stones. Stone analysis is not just one or two methods. Like many people, they know by its FTIR or X-ray dissection. It's a combination of methods. And that is why it is called it integrated analysis. One should do systematically. One should go for optical microscopy or crystallography first. Then this analysis is done by followed by the infrared spectroscopy. This is the list of generally the methods of stone analysis which are performed. But the things which I have underlined are in the regular practice. Optical crystallography, chemical microscopy, and infrared spectroscopy. These things gives the final and most accurate results. Results with these methods are like fingerprint. There is no chance of error. This is how, just to demonstrate, once the stone is received at laboratory, it has been examined and fractured like this to see its inner component. We all know there is a nidus, which is the birthplace of a stone. Nidus is not seen by the routine microscopy. We need to have an electron microscope to see the nidus, which is the beginning of the stone. But one can find, if stone size is good, one can find the apparent nidus also. This is how it is seen. This tells the real story. This can be like, for example, uric acid, but the surrounding stone will be having, it gets deposited. The clinical events, it forms, it makes it bigger and bigger, and it becomes the like calcium oxalate stone. And therefore, one need to take samples from all these areas, and ultimately one should conclude the final diagnosis based on this apparent nidus also, which is seen, which can be something different. And here we can say this causes confusion while we see the stone. If we apparently look to it, it looks like a uric acid stone. But the apparent nidus is of calcium oxalate, or it can be vice versa also. And therefore, the material should be selected if the stone size is good from all those areas, peripheral and the central as well. This is how procedure is involved. This stone is examined under the dissect spatial microscope. Then it has been powdered, mixed with another kind of the powder and pressed, and a tablet is made like this from that powder, and this tablet is processed in the infrared spectroscope. Before that, under the microscopy, all this optical crystallography is done by the experts. So this is how inside this instrument, there is a stored library within the computer, and it analyzes the entire spectrum. The example is like that. This is the infrared spectroscopy. You can see the sample. It is here in this graph. This is the source of infrared. So all the rays they emit, and they just bombard over this sample. This is displayed as a wavelength of the stones. Then they get deflected and from the stone material itself. And there is a change of the wavelength. These wavelengths are detected by the screen over here. It goes to the computer library, which is having thousands and thousands of the composition of different types of the stone. The computer analyzes it and it produces results on the monitor of the scheme. This is how this is the concept of this infrared. The advantage with infrared is it permits semi-quantitation of stone components. It is very specific, rapid, and versatile method. As I said, it is 100% true. It never makes any difference. The main advantage with this technique. It can analyze specimen of any size. If the specimen is visible to eyes, it can be examined. Sometimes we have process like from the debris also. We just centrifuge this, filtered the urine. From the centrifuge material, we just dried it and then we analyzed, and we could find the analysis results also. So this is an advantage about the X-ray diffraction, which is not outdated method. Other advantage, Some non-crystalline materials can also be identified by the infrared spectroscopy. And the best thing is the drugs which are producing stone, which cannot be identified by any other method, can also be found out, which are causing the stone formation. Then some other material like artifacts, they can also be identified, and the computer gives results and tells exactly what is that stone. This is the list of the stones which can be identified by the stone analysis by FTIR only or by integrated analysis. Uric acid, cysteine, struide, drug stones, ammonium uric acid, 2,8-dihydroxyadenine stone, and silicate stones. There is no other method where you can really judge that this is what type of stone it is. So this is another advantage. The reports can be given like this. Can be given against a graph so that one can understand what was the exact site. And here the optical crystallography findings are mentioned. And here you can see this is 75% xanthine and it is admixed with calcium oxalate dihydrate, which is 19%. Other thing is the protein and blood. And all these things are beautifully displayed and it gives exact information. The picture of the stone, whenever patient move from one place to another, the clinician can judge that what was the stone exactly. This is another type of stone. Here we can find out exactly the composition of, there are so many things mixed in this particular type of the stone. And depending on that, one can take the decision. Of course, supported by other investigation. Coming to the significance, the exact composition, it gives important clue that how stone was found. This information may not be available for any other type of the workup. It can identify the factors which are leading to the clinical events, and it identifies the risk factors. How to managing stone? Now we should know the crystals which is forming stone. Stone is made of crystal, so one should take steps to prevent this crystal formation. There is no need to discard stone without any analysis. As I said before, it can have the answer. It might be the first manifestation of many other pathological conditions. Even these crystals on subsequent recurrence can change also. It has been reported that 21% times the stone composition changes in same patient on the subsequent events of the stone recurrence. And again, the mixed stones are the most deceptive stones. This is again as an essential step. This composition can yield the fundamental information about the pathogenesis of the disease, namely metabolic abnormalities, presence or absence of infection, possible artifacts. And this is very important, sir. Many times patient brings something else instead of stone, considering that this is stone. And it is only it is difficult to judge by naked eyes. And everybody thinks that these are the stone, but only laboratory can tell it that this was not stone, but something else. And then again, it can give a story about the drug metabolism, which is causing the stone formation. We can divide into three categories. Number one is the composition and hardness of the renal stones, composition and its predictive values, and then composition and its related metabolic abnormalities. One by one, we are going to talk about this. This is about the hardness. If we consider calcium oxalate dihydrate as 1, then these are the relative hardness of the other types of stone. We can see the brucite stone is more than double in the hardness. You might have felt it while doing the surgery. Hardest stones are the cysteine stones. It is 2.4 if we consider the calcium oxalate as 1. So these are our relative hardness. Why hardness is required to know? It is useful in describing the consistency in an individual patient. The formulation of treatment studies can be done based on this. That number of retreatments required and the number of the shock waves it has to, if at all it has to be given. One can calculate the energy index also. Coming to the calcium stones. Now, calcium stones are the pure, it can be pure or it can be mixed. Mixed stones can have two or even sometimes more than two components. And each component gives clue about the cause of the stone formation. The subsequent episode, as I said, can change the composition of the stone. Most troublesome or more challenging are the phosphorus components. This should be assisted by the 24 hours urinary metabolic profile to know the best results and to formulate the treatment strategies. This is about the calcium oxalate monohydrate and dihydrate, which are two major components of the calcium stone. In calcium, these are the predictive values of the stones. Monohydrate stones are generally having hyperoxaluria, which is about 88%, while the dihydrate are having more of the hypercalciuria. Similarly, hypomagnesiuria, urine in monohydrate is more acidic, volume is low in both, and the hardness factor. Monohydrate are harder than the calcium oxalate dihydrate stone. So depending on this composition, you can judge what are the possibility in the metabolism. Another are the phosphate stones, which are about 12 to 20%. Amongst them are the steroid, which are because of infection, carbonate appetite. The possible cause is infection again, but it is not always. The brucite stones, they are not associated with these stones. They occur, they can transform also from the ordinary, regular or most commonly affecting calcium oxalate stones. The pH in phosphate stone is more raised because of production of ammonia. Citrate is generally less than the oxalate stones. These stones, phosphate stones, are generally bigger. However, nowadays, the bigger size stones are less common. The recurrence in phosphate is just twice or more than the oxalate stones, and it causes more injury to the kidney itself. Hydroxypeptide stones, again, they are calcium phosphate. They can again diagnose only by stone analysis. They can have secondary nephrolithiasis and tubal damage also. One should think about to rule out primary hyperparathyroidism, renal phosphate leak, medullary sponge kidney, and renal tubular associates. I'm just mentioning this because this thing can change the course of treatment also, if we can find out these possible causes. And generally with these types of stones, these conditions are more common. Calcium oxalate with carbonate appetite, it indicates renal tubular acidosis, particularly when the amount of appetite, if it is on a higher side, from 5 to 39%, the more appetite, then more chances of the renal tubular acidosis. For brucite stone, one should investigate renal tubular acidosis because different type studies has given the different conclusion. But if they are continuously recurring, one should think of possibility of these things also, or should investigate in the initial state also. Brucite stones are again calcium phosphate. There are history of multiple ESWL in the brucite stones. There is a significant nephron damage with this type of the stones. The creatinine level is higher and creatinine clearance is low also. This indicates further that it is causing more damage to the kidney. Hypercalciuria is present in more than 90%. Urine parameters are required for all such kind of the patients also. For these types of stones, again, more aggressive therapy is needed, and it's a big treatment challenge. Carbon appetite, a daylight stone, they are generally associated with in the body. Urine is alkaline, there is high calcium and low citrate ratio. It may not accompany by any sign of the disease itself, but it can be a disorder of phosphate metabolism, carbonate appetite. So consider that also, and parasite dysfunction. They are not always in, are very rarely in pure form. They are always in combination with other types of stone. Ammonium urate, they are again calcium oxalate, which are containing calculi, which start due to hyperuricosuriasia. Elders, it is associated with the infection. But while in children, it may also form as the result of hyperuricosuriasia, but no urinary tract infection. So ammonium urate stand in elder and in children, they make difference, and one should have these things in mind when we are dealing with this. Uric acid, we know it is because of hyperuricemia. Uh, the urine pH is high. The causes are, I think everybody is aware of this thing. It can occur because of chemotherapy and radiation also. Steroid, the infection related, mainly the organism is Proteus, but some strains of Staphylococcus and Pseudomonas and Capsula can also cause this urine. Urine is alkaline, and they are, because in India they are more common. Of course, we have noticed that this incidence is gradually reducing. Cystine stones are because of cystinuria. There is it's an autosomal recessive disorder. It occurs as a result of tubular transport of cysteine and some other amino acids like omethylene, lysine, arginine. But this is basically a autosomal disorder. It occurs mostly, it is in pure form. It is about 90% or plus. The management is very challenging. It requires to maintain the urine volume of 3 to 4 liter at least to make it alkaline continuously. Xanthine, again, most frequent cause is hyperuricemia and xanthouria, and absence of one enzyme, which is xanthinoxidase. This is again a genetic disorder, autosomal disorder, and a big channel, right? But this type of stone formation can be triggered by pharmacological inhibition of xanthine oxidase. If we continuously give Eleanol, then this enzyme is being inhibited, and the cases has been reported that stones of this type are found in such types of the patient. So that was about the stone in brief. And I might have gone a bit faster because of paucity of time, but we can just always.
No problem, sir. No problem. You are correctly going, sir. Nicely summarized all these stones.
Okay, thank
Nearly
you.
100 audience, 100 above audience are there. You continue, sir, please.
All right. Now we're coming to another very, very important investigations for stone disease, that is 24 hours urine metabolic profile. And I must say this should be utilized fully. The supersaturation index, which has been done with this profile, is the gold standard, and it tells the real status of this, whether patient is forming stone or not. That is why this is most important. This is only way to know the why this stone is formed, because it reflects the exact metabolic status of the body. Whatever lifestyle a patient lives or whatever patient is eating or drinking, it has been reflected in this 24 hours urine metabolic profile. This tells you uh, how saturated your urine for making these crystals. If urine saturation, supersaturation is high, then patient is more likely to form new and new stone. So ultimately, goal is to reduce that supersaturation, and that is why it's a useful guide. And by doing this, we can exactly take the prophylactic measures to prevent the stone recurrence. This is the entire list, which are the minimum. These tests are done with this metabolic profile to find out the supersaturation, the oxalate, citrate, calcium, uric acid, sodium, magnesium, phosphorus, creatinine, pH, and of course, total urinary volume of the patient. So whenever you ask patient to go for this, always remind patient, don't neglect or don't miss a single event of collecting the urine during that 24 hours period, even when the patient is defecating. This gives, combined together, this gives supersaturation of calcium oxalate, calcium phosphate, and uric acid. The metabolic acid, we collect 24-hour urine collection. You all know the procedure also. First sample should be discarded and subsequent sample to be collected in next morning. At least 24 hours before, patient should avoid thiazide diuretics if the patient is taking for the hypertension treatment or for any other reason. Then taking cake, pastries, they should be stopped, even vitamin C also. So this find out the risk factors in this 24 hours profile are the volume, calcium to creatinine index, oxalates. If primary, then it can find out the hyperoxaluria, then citrate and uric acid. So these are the stone risk factors. These are the dietary risk factors, namely sodium, potassium, magnesium, and then urine analytes like phosphate, sulfate. So mark for accuracy in 24 hours is the creatine. One should repeat 24 urine collection, 4 to 6, ask for that, 4 to 6 weeks post intervention, not immediately after any surgical period. At least there should be a gap of 4 weeks once you ask for this test. Indications, stone recurrence, but more importantly, motivated patients. If patient wants to be investigated in the initial stage, even after first word, go for it, because there is no point in waiting for a longer time and get it done when patient comes, because those things are nowadays patients are also willing to get this done and not very expensive considering the amount of money he spends if the patient gets recurrence also. For one for time farmers with solitary kidney, renal insufficiency, residual stone burden if it remains, and all children, rather all extremes of the ages also. Two older elderly patients should also be investigated. This factor, all those results, this can be now displayed by beautifully in a graph. No, you see these all columns. Initially, by looking, you would find it very complicated, but to make it simple, this is used. Uric acid, excuse me. Uric acid, and this is oxalate, calcium. Uric acid is here, I can see 450.8. So this is displayed in a graph. Now all those things who are in red, uric acid, oxalate, this is calcium, citrate, this is pH. Here, for example, it is 6. So this is here. Citrate, you will find all higher values above, but in citrate, this is 0 because hypocyturia is a risk factor. So all those in red, they are high risk factor and they are contributing the stone formation. So similarly, this is volume and volume of the urine. This is 1.5 liter. The yellow is cut off. This should be within this volume. Similarly, sodium, potassium, magnesium, and last 3 columns are supersaturation index of calcium oxalate, calcium phosphate, and uric acid. Now we see example, the uric acid is very much normal. It is in green and there is no supersaturation of uric acid. Similarly, these things are high. Now supersaturation is high because of combination of these things. We have observed sometimes other things are normal, but only there is a hypocyturia and the supersaturation is high. So while treating, we need to correct only that citrate level. But sometimes even calcium is high, or you can see the oxalate is high, but there is no high supersaturation because it has been balanced or compensated by volume or pH also. And there we can say the patient is less likely to form stone, even though we know sometimes in general population also there hypercalciuria. That does not mean the patient, that person is forming stone. And therefore, This is how important is this graph and the formation of supersaturation. I think you got my point.
Yes, sir.
Uh, this is now, for example, sodium here is very much normal. So patient is not taking much sodium. We can just immediately find it out. But if patient's sodium is high, we can always direct and tell patient, look, your sodium is high, so you reduce your salt content, and that will affect the supersaturation again. This is comparison of a uh, single patient over the period of 1 year. Initial report was very high. Patient is having high oxalate, high calcium, low citrate. Even pH was also abnormal, and the supersaturation was very high. Patient followed the treatment regularly and all the instructions. All these things became, the supersaturation came down very nicely, and patient was not developing further stones. Or even if he developed, the gap period will be bigger. Here the pH is in a high risk zone, but still there is no supersaturation. And we can ask patient also, or we can maintain the pH also to make it further comfortable. So this is how, in a follow-up patient, this graph indicates whether the patient is, the treatment which is advising to treatment is working or not. Management includes, first you know the stone crystal, then obtain proper blood and urine require measurements, screen for systemic disorders also, if any, measure 24 urine supersaturation, lower by half the supersaturation of urine. So the initial objective is to lower the supersaturation of urine to the half, then obtain more 24 hours value if stone is continued. Then follow up every year. Once the recurrence, that reports become normal, then just maintain by regular follow-ups of annually of these investigations to judge whether the patient's treatment is working or not. The conclusion, this investigation reduces and the preventive steps reduces social and financial burden. The impact is mitigated by appropriate metabolic evaluation. It identifies risk factors. We can have focused medical treatment. So instead of random suggesting everything, we can particularly focus the medical treatment and to avoid the unnecessary treatment. It significantly reduces the recurrence, gives better quality of life, and the entire public health system is benefited as the patient maintains its good health. So this is how I wanted to convey. I hope you understood the things in briefly, and that's how I conclude. Thank you very much,
Thank you very
Dr.
much.
Wali.
We will have brief questions, sir.
Yeah, most welcome.
So with your permission, I am stopping sharing the screen.
Sure.
Uh, so I wanted to ask the first question. In RIS, we are making the stone almost like powder. We cannot measure every time 10 grams, 5 grams. Is, can you tell up to 5 or what in what, if you send in saline bottle, will it be sufficient for the analysis, sir?
It will be. Even I give one statement: if it is visible to eyes and if it reaches to laboratory, it can be analyzed.
Oh, great. That's a good,
Even the fluid you drain out, that
ah,
contains that debris, means the dust,
yeah,
that can be centrifuged and that can be analyzed also.
great. That is very useful point.
Yeah.
Second question is, stone analysis generally, metabolic workup and stone analysis. People say better do metabolic workup after the stone removed. Why like that, sir? Why can't we do metabolic workup before?
I think ideally it should be done even before also, so that we can know what exactly was wrong. Once you are treating, just I think this is to save the 24-hour collection rather. and save the cost. Otherwise, if it is done after like 4 weeks, we know the exact metabolic status, and after removal of the stone and whatever treatment you are giving, and
And
then you can take the further judgment that what further instructions to be given to the patient.
normally,
Otherwise, I think
when we send the sample to the lab, it will be sent to the saline.
the stone doesn't require anything, any preservative. It should be sent dry. Rather, it will be better if it is sent dry, because the laboratory requires to dry it for another 24 hours.
Okay.
So mostly what happens, there, I think staff makes that mistake. They put in formalin also sometimes,
No, no.
and that spoils everything. Then it becomes very difficult for us also. And for urine, preservative is just uh, it's a 1N and hydrochloric acid, and that transportation. The good thing is that doesn't require any refrigeration. It
Okay.
reaches, and the
After you receive the stone, generally how many days it will take for the report to be given?
it takes stones are reports are given next day. But
Next
this is
day.
a very fast method. Yeah, we give time to dry it till next day, and then it doesn't take much time. So we display reports can be dispatched within 36 hours. Both, even urine also, because urine we need to collect number of samples, because all batches are to be done simultaneously. But now we
Urine
have that
sample,
machine.
urine sample, 24-hour urine sample, how to send to the lab?
It actually
For
we need
example, I
help.
want to send to Ahmedabad. Is it possible?
It's very much possible.
How is it
We,
possible?
we, we don't laboratory don't require the entire 24 hours volume.
Yeah, yeah. You mix it and write the
Sample is
volume and then
collected.
send.
Yeah, we need things, 2-3 information. Number one, what was the total volume of the um, urine collected for 24 hours volume? What was the pH of fresh urine? So that pH is required there from the fresh urine, not from the preservative urine. And if patient is below 12 years, we need to know the weight of that body weight of that patient. It
Okay.
can be transported in a very good leak proof container. Generally, hospitals which they sends to us regularly, we have already made a box, and that is only with a tube. One need to put the urine samples, and it's a thermocol box, so it can be transported it's a self-addressed box. It can be transported very easily to the laboratories.
Okay.
This
So
is
by no preservative, just directly will tender.
preservative. You need to help at least one technician. We guide them what are the preservative. It is better to add preservative and send. But otherwise, we have done studies that if we add preservative after sample reaches here, the values are not affected. But what happens? Preservative means we need to acidify urine to prevent further bacteria formation. Because
So
during
once
transportation,
you take the pH, you acidify and send the sample.
yes,
How much time it will take for the 24-hour urine report to come?
transportation now in India is not, I think it has improved quite a lot. Most of the courier services, they deliver within 3 days time.
3 days. Okay.
Depends on
After
the
you receive the
distance. Then
sample, how much time it takes for 24-hour urinary analysis? I mean,
next day. Now, because the volume is good, we put all the batches and reports are
how much
within
volume has to be sent?
15 milliliter. That is sufficient.
And that preferably you are contain it like a watertight type, whatever blood we take, such type of thing, same thing.
Yeah, yes. It should not leak or
Leak, leak,
damage.
leak. So, and you are giving self-labeled box also for that.
Yes, that we can provide.
You keep it inside and then give to courier person.
Pardon?
You give, you just keep inside and give to the courier person, writing the address from where it is coming from. That's all.
Yes.
And generally, do you have any variations or first time you do only basic urinary 24-hour profile or standard profile you will do?
We recommend only this profile because supersaturation can be done only with this number of investigation. And I believe without supersaturation index, I think the reports are confusing, because if there is a, like for example, hypercalciuria, you would never know, or even high oxalate also, you would never know whether stone is being formed or not. But if
Do you think
supersaturation,
that by looks of the stone we can identify stone composition a little bit? That one slide it was missing. I thought I will keep it. We identify only calcium oxalate monohydrate, calcium oxalate dihydrate, uric acid, and sometimes cysteine. Other stones little tricky to analyze. Anyway, it is not correct to
this,
imagine.
eh, one thing is this can be deceptive also. As I said, the apparent nidus contains uric acid, and when you see by your naked eye, you would feel it's a calcium oxalate stone, but the story can be different.
Yeah, yeah,
Secondly, this is not a very expensive kind of investigation.
yeah.
Patients are nowadays willing, and there is a documentation also. Yes, this is the stone. So always laboratories are accurate. Whatever our personal perception can be, we can make, anybody can make mistake. And it has been found regularly.
Do you mind telling rough cost of the store analysis and rough cost of metabolic? It varies or generally it is more or less fixed? I mean, no conflicts of interest. Out of curiosity, like how much patient should get?
Yes, yes.
Because most of the time when surgery is done, they might have already given 30,000, 40,000, 50,000. They will be unhappy to take again sample for 3,000, 5,000 like that.
Actually, the cost of stone analysis is 1,000 rupees, and the metabolic profile is 4,000. And
It's
this
a
has
lot.
not increased since last 10 years.
Oh my god.
Yeah, I want to promote this thing. My mission is to work for the prevention of stone. And you know, the cost of everything, the high inflation, even the imported, this kits are, all these things are getting more and more expensive. Salaries are high. We all,
Being a pathologist, how did you develop so much interest in stone related? In India, I heard your name only predominantly in the conferences you come, and your lab is also known. What is the reason why you selected predominantly this type of?
very interesting question. You know, I was owner of a hospital. It was 100-bedded hospital, and we gave it to one very well-known company.
Hmm.
During that time, many of my urologist friends used to tell me that why you, we are not happy with the laboratory's stone report. Why don't you do something for this?
Hmm.
So I thought, okay, let us go for this inning for this particular cause. I inquired in USA. There is a lab which is, they are world leader. I wrote to them that I want to learn this thing. I want to work with you. And initially they refused because they said we don't allow. But when I said, look, this country is suffering, and we are not having so many, means having stone patients. So, and then they just allowed me, and I was there for about 6 months with them, and I worked, and then I decided. And good thing is that many of our teachers, senior urologists, they encourage me, like Dr. Mahesh Desai sir, Sapneet sir. I met them, and there are many of my friends here in Ahmedabad, all around. Like, I'm very fortunate to have many good friends all over country now. They they encourage me.
And what
One of
about
them said, "You are
how many stone samples roughly you'll be doing per month? Just out of curiosity,
how many stone?"
samples. How it's busy like a lot of people from India refer.
Yeah, we have, miss. Your voice is not clear, but we have so far. And I think if I have to check. It must be around more than 80,000 stone. And
Okay.
we get, fortunately, this lab was involved in many international studies also. We
Okay.
recently published a paper where stones from 10 countries
Very good.
were analyzed, and one fellow from the Middle East. He did this primary study, and
Okay.
it was published very recently. This is how the academic things goes on.
Okay. So thank you, sir. Nice information, and I think last my questions make sense. It's only 1,000 rupees stone analysis and 4 to 5,000 metabolic workup is not very costly, especially bilateral stones, multiple stones within 1 year if they are forming children. The volume of the stone is big, and if it is associated with abnormalities of the congenital tract, these are the absolute indications. And nothing wrong in getting a stone analysis done if it is so. Even I got good information, first-hand information by interviewing you. I hope this presentation will last. This YouTube link will be there forever. Anytime they can watch and get information. Especially your presentation has crispness about the stone as well as the metabolic workup for the PG's exam going theory. If they want to write, they can read this and go. In that way, it is useful. Even though it is not surgical technique, I included because lot were asking. I hope it is it will be beneficial for our pure urology group. Thank you once again, sir. Mehta sir, thank you very much.
Thanks for this wonderful talk.
Thank you.